on Medicaid fraud. Remember that? Okay. Let's try going around and seeing what the general picture you all have of where the varieties of health care, so we're contrasting ambulatory care with, say, hospital care. First of all, out of $1, what's the biggest share go towards? Out of any? Oh, we all know that. Okay, about 40%. The figures, as far as I know, have not varied that much. We're pretty safe in using this, detailed 79 stuff. So there is some later stuff, but I don't know that anything moves, as much as 1% from what's known. There's a much bigger share of the gross national product, going for health care now. It's up at 10%. At this time, like in the new Hauser readings, it's still at, I think, 9%. Oh, how much out of every dollar, about what proportion do doctors get now of the total dollars that are spent on all health care? If hospitals are taking 45 cents, anyone got the figure? How much? Huh?
21.
All right, well, about a fifth of it goes for dollars. About a dime a piece, or 10%, 9% for nursing homes and pharmacists. And you'll see that's very different as to where it comes from, terribly different as to where it's coming from. That's as far in contrast as you're going to see. Dentists, about 8%. And then let's talking about who that gets the last 8 cents out of each dollar. We spent 92 cents. Name what, let's call out. What kind of fields haven't we covered? Huh? All right. Well, if it's not if it's not counted inside the dollars, right? Physical therapy. What kind of doctors, called doctors, are not included? Huh? We're not sure that these aren't physicians, okay? The way they usually in other places give this figure. Eye vision stuff, right? And may include optometry, depending on how they've, different people do this differently, right? These are sometimes just MDs and DOs, and we still don't know about optometry, podiatry, depending on how they do the dollars, okay? What other things? Okay. If they're not, again, remember, certainly psychiatry should be here, but sometimes psychology is not. Depends on how they're using this phrase, doctor, another list, okay? How about all the appliances, the home health service, right? All those kinds of things, okay? So you can see how little they amount to. Now, jumping from that to taking all providers again, the entire dollar, not dividing it by who gets it, but where did it come from? How much comes out of the patient's own pockets of all the health care expenditures in the country? Huh? 1/3? That's right, okay. And the 2/3, let's take a look at and see if I put some stuff up here on the board. Let's take a look and see if somebody can tell me what we're dealing with. What do they think this is? We're talking now about the third parties. What do you think this represents?
Government.
Huh? Okay. This is government. Of the government's 40%, what's the biggest single share? Who? What? No, I don't mean by federal state. What?
Medicare.
Medicare. Okay? Medicare alone of all governments, any kind of government, state, federal, county, municipal, everything, 16%. 12% is a mixture of federal and state shares of Medicaid. These are rounded, 0.5% off or so, okay? And the last 12% are local, state governments for, expenditures for other than Medicaid. Oh, give me examples of that. Anybody know? I mean, Arizona never got under Medicaid. It just has an even more expensive. It thought it was going to escape the disaster. Instead, it ended up with disasters and bankruptcies in Tucson and Pima County, a number of other places. Huge expenditures for local hospital systems to take care of it. It can be expended in a lot of ways, can't it? Can't you think of all the ways that they spend this money? I mean, the mental hospital, just think of everything that's going on. Okay? This, what is this kind of money? If this is government money, okay? What's this kind of money if it's third parties? Huh?
Private?
Yeah, private. Now we're dealing with private third parties, okay? These are the third parties. We're talking about the 2/3 of the dollars, you know, and where it's coming from, okay? What is the, what would you call who wants to guess at how the privates break out is between the major ones that you nickname? Huh?
Blue Cross.
All right, Blue Cross Blue Shield. Then what's the next one? What do you call them? Let me hear it again.
For-profit.
Okay, commercial or for-profit insurance, okay. And this is actual corporation, you know, direct expenditure right at their plants, right? You know, direct health programs, that kind of thing. It's about 1% of third-party payment for, and not through, you know, since patient doesn't pay, but the employer's paying without going through a carrier. Okay, we're examining where the dollars come from. So when we say 1/3, it's about close to it. You know, like 32% is coming at that point from the patient's own pocket. Now, that was the total dollars, okay? Let's jump over here and see how different it is depending on whether the hospital, physician, okay? What do you think this one might be? And what do you think the hospital's biggest line is? Where does the hospital get most of its dollars from? Out of all that, huh? What?
Medicare.
Medicare is the biggest single thing. Okay. That's going to be what? When it gets way over, I hope, when you get to, I'm sorry. Private insurance is the biggest thing. Private insurance is bigger than that. This is going to be, okay? Okay, you get the dental, you get the drug, you see what Medicare is, huh? The biggest is private insurance. In other words, if any employer, if he doesn't have much insurance, he's going to get his employees hospital insurance, okay? If there's almost no bargaining going on, and then you get Medicaid, okay? Now, watch private insurance, right? Still bigger for the physician, isn't it? Dentistry might be an increasing factor, you know. Now, here's where I sort of give you warnings, you know, more and more collective bargaining, 79 on, might have resulted in, you know, a higher percentage here, more dental insurance than it was then. Pharmacy, more drugs, okay? And this is nursing, okay? Pharmacy is not much insured. Notice Medicaid, Medicare for over 65s, pays 0 on dental, 0 on the pharmacies, and is not a big payer to nursing homes. Who's the big payer to nursing homes? That's right. And to dental, pharmacy is not almost equal to private insurance. The doctors, it varies. We had some examples of doctors that run Medicaid mills, you know, all of them there. And hospitals. This is very important then, that this is where the dollars, where it's coming from in general, if you look at the broad sweep from a policy point of view. But when you start to make policy, you're going to see where the screaming's coming from. You know, when you're clamping, in other words, you start talking to nursing homes about capping their number of beds as they're doing, okay? And you're talking, you know, their lifeblood. If the Medicaid agency is talking about capping just the numbers of beds, you're talking about, they're already in, say, North Carolina, this association is going bananas over just that idea. They can't add beds. You see, if Medicaid will freeze at whatever the number of beds, they'll never pay for any more beds than they've had in a certain year. They almost have to find out where should they put their future investment dollars. These are proprietaries for the most part, right? And they're trying to figure out where to break out at. On the other hand, you're not going to hear dentists making, you know, a great deal of noise about as much as other people are going to be making about these kinds A lot of doctors are at zero here, right? You know, doctors that would almost not accept Medicaid patients. Any other comments? How about some observations about what all that means in policy terms? Where is the government concerned? Where are they going to be capping prices? So how are they going to cope with this huge thing that's going to bust the budget? It's busting the states when they shift the burden to states. It's how would you go about it, Ms. Holland? Where are they going to? What are some of the ideas they've thrown out?
The government is thrown out?
Yeah. Pretty concerned about this, aren't you? This would indicate that all the taxpayers are putting up a lot of the money for the furnishing of all medical care in the U.S. And if you carry it through and look at these two, you look at it any other place, it's a big part of how much of this is tax money going through the state and federal. What ways are there of dealing with that?
Place limits.
Huh?
Place limits.
All right. You can place, what, dollar limits, one way? You can prepare, I mean, with anyone coming that's a government bureaucrat, federal or state. What'd you learn from reading those 1970 hearings? Did they show you anything? How did all this thing get the way it is? I tried to throw it in real fast. They only had about a year and a half's experience. They hold the hearings 69, they publish them in 70. How much did they know? And what's already out of control? I mean, they're talking about capping now. Well, when did they let it all get away? Yeah, they let it all run away from. Remember, the senators here, the congressional hearings are pretty angry that, that they let the carriers do this. Huh? Who let the carriers? I mean, how did that law get like that? Huh?
Heavy lobbying.
By whom especially?
AMA.
Yeah. The AMA opposed Medicare, and they were defeated in Congress. Some people said they lost the battle, but who won the war? Because they just got one phrase in there, that in between Social Security and the doctor or the hospital would be fiscal intermediary or carriers, you see. And this is the way they would have the dollars, but they couldn't deal with these people direct, say the way the mine workers could, say you're off the list, you're on the, they couldn't say anything to them directly. They had to talk through these people. And these people for years, well, let's say who's on the board of Blue Cross? A lot of this money is Blue Cross Blue Shield, isn't it? Who's on the Blue Cross board? Typically. Huh? Hospital administrators, hospital trustees. Very often a majority. Only recently by law have consumers gotten seats, How about the Blue Shield that deals with doctors? Who established them, first of all? How did Blue Shield get established in each state? How did it get a statutory base as a nonprofit? Can you open up a nonprofit under that statutory enabling legislation, you think? Suppose you all wanted to open a nonprofit. Do you think you're allowed to? Most of those laws were put there by the medical societies, and they control the boards. And only recently there's even the idea of putting many consumers on their boards, coming to even a consumer to take the bill. So what you were looking at in those hearings, did any of you compare those columns and look at it? Anyone remember any examples? Want to cite any? What was it?
I just noticed that anywhere from the Blue Shield would pay half to, say, 2/3 or 3/4 of what the Medicare average payment was, or average allowance was. I noticed one that glared out was the fact that in New York, there was one where they paid less, I think a couple dollars less, $3.73 versus $3.75 on Tennessee or something like that. They actually...
You said half to 3/4. Was that true on some of these? Anybody have any that they remembered were even much more outrageous than that?
Yeah,
Alabama.
Huh?
Alabama.
On what? Give me an example on Alabama first.
Everything.
Huh? Look at, what's that, electrocoagulation of the prostate? $75, and the first bills they paid $371. Okay? Look at cataracts. They'd been paying $75. Cataract, how long does it take an ophthalmologist to do a typical cataract operation? Anybody have any idea? Suppose there's no problems. How long is he? We're not talking about his scrub time. Anybody have an idea how long it takes him to do a typical?
45 minutes or not.
Well, and a fast operator, about 20 minutes. If he's got 10 operating rooms and they're keeping them open, he can move around pretty. I'm not. It's the whole point. I'm saying no complications, simple cataract. Okay, you're talking about where already everything's skewed because they're not going to give, remember, the internist $75 at that point in time for an hour of life saving in a coronary situation. You see, they're going to pay him probably $25 at this point, 1960s, you see. So the surgeons are already favored, you see, already under all these schedules. And along what causes the inflation is this kind of thing. No matter what the doctors build, they're in the habit of not arguing with them, you see. So that you remember, who remembers some of that argument in those hearings? What were the words that they were using? Where did these words get into our language that you all accept now? What are some of the words that are connected with fees? What kind of fees?
Reasonable and customary.
Usual and customary, right? And the debate is, they become terms of art. You know, the words. What does that mean? Is it what the Blues have considered, the commercial insurance have considered usual and customary? You see here what they're paying. And the debate is, isn't that what they should have protected the feds on, you see, by what they considered it? What was the opposite argument?
Question to that. There's a statement in here that says it's the Medicare administrators that disallowed the fee schedules that the carriers were using. So blame is going to be placed on letting the Blues say that much was owed, then it should go to the Medicare administrators.
Who are Social Security administrators, you're saying?
Yeah.
Yeah, I think there's a very heavy burden placed. Huh? How do you account for that politically? I mean, what do you think their argument was? That while this is the way this congressional report is leaning, they believe that Congress' intent had been shown during the course of the whole thing strongly to lay off of these people. You didn't want us to police them, you know. You see what I mean? They are not, remember, they're probably new dealers, they're probably not that friendly, but they were kept away from the doctors. See the distance? These hearings are quite angry and are giving one side of it. The administrators are not just bureaucrats trying to give away the federal dollars. They believe they've read it another way. You follow me in the congressional intent? And they arrived at the conclusion that you called our attention to, that they had no option but under other intent shown in the course of passing legislation and the debates. You know how they go at when they look at a law and it's been debated for 6 months or a year heavily in the Congress, then they're looking at the debates in Congress, they're looking at the reports of various committees, you know, they're looking at the intent shown. And this is an angry committee, you see, looking at the inflation, and they're taking a very strong viewpoint in issuing this report for after the 69 hearings. I thought by jumping back you could get some idea that the last people in the world that ought to be screaming that the feds don't know what they're doing and all of the very, see, we're in a topsy-turvy position, are the very doctors who lobbied all this. Usually it's their journals that are now saying the feds don't know what they're doing right, federal programs don't know what they're doing. They got the whole thing into this shape by those amendments, you follow me? They intended to get it. So that they turned from opponents of Medicare into people that enrich themselves from Medicare. What else does a fee schedule like this mean? $345 in Alabama for a cataract operation. And when they build Blue Cross Blue Shield, they're being paid $75 by private people, you see. Many of these elderly were much lower income, you know, people and on average than their own people. They may not have liked the schedule, but in some cases, if you drop down to Utah, you'll see a state that tried very hard. We're not talking about them being Mormons or anything else. You're just talking about a blues that tried to get a handle on this thing and not let it. You notice that although they let it get away on some things, they're only $2 apart. Look at gallbladder operation, the fourth one over, huh? You know what I mean? That type of thing, they really sat there and fought it out, you know?
That North Dakota, it's like they paid more in some instances privately.
Yeah, or it was at least, if you mean North Dakota, do you? Yeah, the first column shows, and the second, but then it is it always? You see, it doesn't. It's glaring in some things, and then it gets so many footnotes you lose track of whether the footnotes are explaining that they're not letting it flow out on the other five to usual and customary, because they sure don't put in a figure, you know. All I'm saying is it was not an even picture, but in general this table is one of the most valuable because it gives you an idea of how this thing was gotten away from everything immediately into such inflation that it's unrecognizable. You see, you all don't realize how this backflowed into insurance. It ran up employer insurance premium costs, it ran up worker premium costs, it ran up everybody, it doubled back. These became the usual and customary governing, you know. Today it's something you all accept, that there is a standard usual and customary, you know, and reasonable thrown in, all these words, you know. When, how do they go about that? Anyone, some of you have had a grounding in this financing. How do they go about determining any of this now? Is it a pretty technical procedure by which they define each of those words?
Well, I know in
Yeah.
home health, when they're looking at reasonable costs
Yeah.
for a given area,
Yeah.
they look at the administrative costs as well as the cost for services and determine what the average is. The average cost is for home health agencies in that given
Okay.
area. And then plug in
What does customary mean? The first thing they're determining is this what this doctor, they're getting a bill from, customarily charges. That's the first thing. Has he like billed $10 to Medicare and billed $5 to everybody else? Follow me? So the first thing they could catch him on is that it's not his customary charge, okay? Okay, that part is relatively simple. He learns quickly, like the poor people learn what magic words, you know. You all know there are more graduate students in Chapel Hill on food stamps than there could ever be poor people in Northampton County, because they've learned all the words to answer, right? When the social worker comes around, you know just what to say. The Cadillac doesn't belong to me, it's Daddy's, okay? He lends it to me. They learn how you can go to school on food stamps and on welfare and everything. You learn how to give answers, okay? The doctors quickly learned they were doing the wrong thing, right? Customary, so they stopped that, right? Up in the bill for Medicare. You don't do that anymore, do you? Now, yeah, go ahead.
Well, one of the things they do, at least in Raleigh, certain groups, like pediatricians or obstetricians or whatever, get together and set their fees. Whenever they're going to raise fees, they all do it together. So,
That makes it,
That's just half is half. They don't get
what would happen to them if they did, Mr. Yao? Why would they not get together, huh?
illegal restraint.
That'd be illegal restraint of trade, it'd be trouble, so they hold a dinner, you know, to honor somebody, right? I mean,
so it's an informal gathering.
yeah, right, it's an informal gathering. There was a great pediatrician lived in Raleigh 125 years ago, and we're gonna give him a medal tonight. And while they're all there, they chat about their office. You know, they're just like big business, Jack. They're not that stupid. They were that stupid, but again, they learned like this, not to make that. The first thing the law came along, they all just doubled their fees and sent it into Medicare. All came back and says, is that your customary fee? No, so they upped their customary fee to that level, right? Now it was legal, they sent the bills back in. I said, yes, it is our customary fee. So that's the other thing. What was the next thing? It became the usual charge in the area, right? See, the devices like that. And reasonable, anyone define it differently? It's a blurry term, isn't it? I mean, you see, I think Ms. Harris is saying it's, in some ways, they're looking at, is it related in a reasonable way, you know? But you have to, They do it by areas too. You know, they have areas. Like Durham and Raleigh may be an area, you know, different than Asheville. And small. Who gets the shafted the worst? Where are the lowest fees? Anybody know? Say under Medicare. Anyone know where the lowest fees are? Like, if you had to describe it demographically, where's the worst payments coming from? Rural. There's a pure dollar flow from rural to urban, okay, for the same procedure. And therefore, per beneficiary in rural states, there's much less expended than, say, in California, New York, or urban states, okay? And that's been determined over and over again, okay? That since you can say, well, the people use it less, but actually on fees, there's it's just like some people believe, you know, welfare is used for the same purpose. It's a transfer payment that may look like it's to the poor, but, you know, in total, all federal transfer payments may be to the middle class from the poor. You know, there's been studies indicating some of that, too. The very latest administration budget things, what is the shift this year? Just so we're talking about shifts of dollars. There are cuts of the poor, right? There's no question there are more cuts hitting the poor program. But who is it that's getting, if everything was adopted that you asked for, who is the next class that's getting hit very hard? This year it's the middle class. See, it's a whole series of shifts in the way the budgetary proposals are made, and this is a constant. If you look at like cataract surgery, you know, in certain rural states and compare it with, it may be that they will allow in San Francisco, L.A., Chicago, and New York, $875 now. And if anybody in certain areas in rural states turns in $475, it may be declared as above the usual and customary. And that stands. Seeing that you can't cite national data in your area, you see. It's like, there's one other device. Anyone know other devices Medicare has used as the money's flowed out? It's your computer, what's the word? You know, it's how you look in the computer for the last 2 years. They like freeze you up. So suppose a doctor's been honest. Everybody else has got typical internist primary care visits up to, in his area, to $25. And around here that's low, right? We all agreed that would be low for seeing an internist briefly, okay? Because it's been 75 around here. But I mean in a lot of areas. And suppose some guy says, there's no reason to charge people like that. He's still at 15, even though he's an intern. Now, if I work him up, I'll charge $50, you know, but just seeing him for a few minutes about a cold, it's going to be $15. What happens to him is he gets locked into his own image in the computer, you see. They've thrown that at him, too. They got technical terms for all that. In other words, he can never get any more than he got 2 years ago last July, you see. I mean, if they're putting caps. So caps, which look like devices to control costs, can become terribly burdensome on the most honest of the doctors, you see. The ones who have actually been like they thought it was on, it just is like morally wrong to keep raising fees as high as some of them have gone. You may not believe there are any moral gods, but you know, if you look at images, you'll realize there are.
A way to get past that, though, is I think it's a 2-year period that they look back to.
Yeah.
And if you can justify that your cost was a lot higher than that $15, they will allow you that much.
Yeah, there are ways out. You can appeal. You can do other things. There are small clinics. You can come under, say, a Rural Clinic Act. You know, if you're only charging $5 or $10 and still be reimbursed, if you're rural. And a non-profit will be reimbursed under the Rural Clinic Act by your costs. So you may get $28 for every encounter, whether it's worth $45 on the fee schedule or $4, you know, because they go dividing by the number of visits into your total, you know, your budgetary costs and actual costs.
This rural thing, is it just because in urban and these bigger cities there's more money available, there's more
No, I
programs?
think there's many issues there. Can any of you think of some of them? What about rural people? What are some of the issues? Well, why might there be a dollar flow from rural states to urban? How many reasons can we think of? Under the Medicare, Let me explain everything about this federal stuff, so before Barbara Matula gets here. You think the only fraud is Medicaid fraud? I gave you horrendous examples of Medicaid fraud. You think that's the only fraud going on? Huh? First of all, does anybody think there wasn't some fraud in those cases? I tried to give you some horrendous cases, right? They're not textbook ones, they're ones I've encountered, you know, in the press or something, but they're better than any textbook one, because it's like, you know, you can't imagine, if you'd seen this as an example, you'd say that damn professor's made it, you know, up. It couldn't exist that anybody pull this off and be aided by administrators. I mean, nobody stops it. Nobody says go get an injunction to get the money out of us. You know, they could have done a lot of things, right? They paid them after killing these people, okay? And it's murder involved besides, right? If you look at the, you know, what's involved in handing out the stuff that was being handed out there by calendar, right? You think any of the crusaders can, an investigative journalist can get anywhere? I mean, you'll meet a PR vice president and they'll talk to you for days or months, weeks, anything you want to be talked to. They'll put more vice presidents on charges and keep talking to you, right? But are you going to learn anything? Now, why are they so quiet about it?
Public image?
Well, I don't know. I'm just asking you all. I'm not sure, but part of the reason is, what do these people sell besides health insurance? How many kinds of things do these people? They're in business, right? What do they sell? What?
All sorts of other...
Well, let's take the biggest thing. So what's all? What?
Metropolitan.
Well, Metropolitan. Take them as a big one. Prudential. They're companies. Now, what's the biggest thing they sell?
Life insurance.
Life insurance. That's the first thing. Now, who might be big buyers of life insurance in the U.S.? Who would buy $1 million without blinking an eye?
Companies?
Company, corporate presidents, right? Bankers. I mean, not the Joe right down the street. He'll buy 10,000. He'll buy 20,000, right? Who's going to buy maybe a paid-up one or a $1 million annuity? Aren't MDs going to appear in here? Yeah. Huh? Now, if MDs don't appear there as customers, why else do you need them? Because they must examine, you need good relations, the millionaire that's coming in and wants a $10 million policy. And they must get a straight report from him, even if he wants $500 an hour, you know. They want a straight report. They don't want him angry, do they? I mean, this guy may be alcoholic, he may be really dangerous. He may be, you know, have cirrhosis of the liver. I mean, without testing it yet, they want him to be terribly candid with them. You don't get these people angry, do you? They're customers, potential customers. They're in the whole process. What else are MDs very important about? They're the conduit for many people, you know. You know, it's just like you may ask, if you're betting on numbers, you might try to pick a bookie type. You might go in a bar, you know, to get advice. But a lot of people ask doctors for advice, don't they? I mean, what if I need it? What's a good insurance company, doc? You deal with a lot of them. I mean, you know, you don't get them angry, follow me? They are the providers that they pay to. I've already been over these people. They are the same thing. Okay? They're not going to tell you about themselves. They're very careful when they turn. I mean, do you know what goes on inside a tissue committee? I mean, there's some bad hombres, aren't there, in some of these hospitals? But the tissue committee doesn't talk, do they? Or, you know, they've been taught. Am I wrong on this? Is this published around here? Huh? Tissue committee data published? The main committee is in a hospital, the tissue committee. What's the main committee? What's a tissue committee do in a hospital? Come on now. I can't believe you all fooling around medical care this long and don't know what
They
a
go
tissue...
over, they
Huh?
go over the tissue they take out and stuff. And
Yeah,
tell you
yeah, let's say there are 13 surgeons, general surgeons in this Raleigh hospital, okay? There's a tissue committee, and it receives from every bit of surgery, a piece of the tissue goes to the pathologist, right? Now, the pathologist reports to the tissue committee. Say it's 5 doctors, and they say there's 105 on the staff of the hospital. as they examine this, everything is pretty orderly. In other words, there are appendectomies they're going over now. And about, out of every 10, there's one maybe of normal tissue, okay, or 2 of normal tissue. But, the guy's not God, right? He thought it would look like a hot belly, and he did the best he could, okay? And all of a sudden, Dr. F, and he will remain Dr. F, okay? All of a sudden, Dr. F, this month, like for all months we have examined, has 5 and 6 out of every 10 are normal. And next month it's 7. Normal tissue, okay? Now they will call in Dr. F and talk with him if they're a good committee, but they still won't tell you what's going on, okay? Right? I mean, George Carlin, you stay up late enough to watch him on Johnny Carson show? Nobody stays up that late, okay? One of his nice remarks you don't want to forget is, come on, folks, imagine the worst doctor you know, every one of you. Think of every nurse you know and ask her to imagine the worst doctor she knows. They all know one, right? Now multiply by the number of nurses in the USA and know that tomorrow morning 40 or 50 people are going to be going to that worst doctor that everybody knows, okay? But he's plainly the worst. I mean, that's what's, is there too, okay? That's part of medical care. But you don't know. These people don't let you know. So when I give you these examples, don't get your eye off the marker. Don't let me distract you onto fraud. Ask you questions about fraud, but remember I warned you. It's because we can get at this that we know about it. Some of the worst of it's over in here too. Also, what about the poor? They're more vulnerable to this, don't you see? I mean, they could be, those cases were cases that could be taken advantage of, right? Living in the ghetto under horrible conditions, trying to be a singer, and trying to get helped up. A doctor, there's middle-class people are people pull them back from the brink, and all this kind of thing. So that these people are preying on the most vulnerable. What about, let me jump back to rural. Come on. Some of you have studied these kind of matters. What's the nature of rural people that might cause them not to have as heavy expenditures? What are some of the things we know about?
Well, they don't utilize health care.
Okay, utilization. Why would there be lower rate of utilization?
Part of it is where the health services are located. I think you have to look at
accessibility.
Right.
So you're saying the very fact that in your county there's only one doctor, and it's a county, many of, say, Appalachian County or North Dakota County, with, it's huge mileage in between. There's only one doctor in it. It's a poor county. It's hard to get to. Some counties have no doctor, right? That's less and less true, but it's still around, right? Accessibility.
Travel.
Well, what else affects where accessibility, travel, cuts it?
Cultural and custom.
Yes, cultural things affect this. What kind of cultural things? Give me some examples.
Well, the fact that people might have a lot of home remedy kind of things. Or
Right.
They don't go to a
Yeah,
professional
right.
or something's wrong.
Why would you go to doctors for them to, very well Miss So-and-so is well, and they decided she needed surgery and they killed her, and as soon as the anesthesiologist got to her, her heart stopped. I mean, they know those stories. Nurses know about it. They never get into the OR. They die right out there as soon as he goes near them. What is it their, is it their fear that kills them? Is it a reaction? We don't know, but they're reported, cases, and they know them well. And that didn't happen when you did what Grandma said to do about this, right? And Grandma's chicken soup works, and all you educated people going back to it, right? The goddamn Carver, all these places, Berkeley, are full of natural food and garbage and all this stuff, it's all back to the land right now. Grandma's come back into virtue, right? Now that you got all the environmentalists and Sierra clubs, all this stuff's all, So why wouldn't, there's nothing here, right? The doctor knows no more. How about how Mexican Americans feel about it in the Southwest, about Anglo culture? What are Anglo scientists like compared to their own healers? or Indian healers. What do you think they're like? How do you think they would regard? What?
They'd probably be suspicious.
Well, suspicious, but worse. Aren't they cold in person? Aren't they uncaring people? These anglers, I mean, they're microscope people. This guy holds your hand, listens to your story, they're healers, and, they stay away from this system, okay? So there's a lot, I'm talking now about different culture, Appalachian people might have their own reasons, other rural people might, so there are cultural factors. In addition to those, there are the factors that the intermediaries interpose, you follow me? A board-certified pediatrician settles in an Appalachian county and charges $20 a visit. Instead of saying, thank God, first board-certified pediatrician, and they're charging $30 in Pittsburgh and in Knoxville and everywhere, and he's out there nowhere. Oh no, they got ways of dealing with that, right? His competition are a bunch of GPs that vary from $3 to $9, right? So he's locked in by somewhere you're locked in by $7 average or something, okay? In other words, there is that factor, as I gave it to you on surgery. See, a much lower, the carrier imposes discrimination. The net effect is that studies have shown that in rural counties, divided by the numbers of people, it is remarkably lower than in urban counties. Because after all, in ghettos, there are people who are scared of doctors too. But, but still with all those factors, the Medicares, again, these people don't publish that much. They don't give you booklets you can get. If you write, you can get a Medicare booklet showing every county in the U.S. and what they paid, you see, per capita, in total, to how many carriers, without their names, all this kind of thing. Asterisks if there's too few, all that kind of thing. But there's none of this available. So that, remember, on fraud, on utilization, on all these things, we're knowing more about it only because these are government programs which have to report. Otherwise, we'll be distracted away from the fact that they're shoved around, they don't have enough money for the people, and all that, and we're getting away from their problems. Suppose you were in the administrator's shoes, how are you going to deal with, the lesser budget, or the shoving onto the states of the problems which is taking place?
Is Blue Shield and Blue Cross, are they required by law to post the amount of fees that they pay their employees?
Their
Not
providers.
fees actually, but salaries. Like,
Okay.
I'm wondering where all that money goes.
Oh, you mean, I don't know. I think there are some states that have become more unfriendly to them. Not only putting consumers on the board demanding much more detailed reports, but that varies. In this state, they were very untouchable, and they still are the biggest carrier. Not in some states, they're not the biggest carrier. Commercial, combination of commercial insurance companies may be far and away the biggest. In this state, it was only recently that the state employees, the biggest of all groups, was lost, to Blue Cross Blue Shield on bidding. And most employers in this state are still connected. There seems to be a very good cohesion between the big business leadership and the Blues. In other words, they have very heavily moved their boards towards the big business leadership of this state, so that they resemble the board of trustees of the great university more, I'm trying to be cynical, on this point. The trustees here were moved a long time ago over to being in charge of Winston-Salem and similar places. They gave it all away a long time ago. And that's what they've done here. They've got a very nice marriage. So the big companies tend to be Blues here. In some places, they're very suspicious of Blues. They say private industry is where we ought to be because we're private industry, see, for profit. They're ideologically down there, not in this state. What about, we're on payment, and assuming our speaker's going to make it from Raleigh, what about if you took the readings that you were given, and let's try to talk about, be sure we've got together the definitions that we ought to have. Now, I'm not trying to do that little table, that little exercise that the text gave you. The more I did that exercise, and he showed the 3 ways of showing a deductible and a coinsurance, I began to realize I think it was a puzzle rather than a table of explanation, because I could reason it each way and wondered how could he come out with 3 ways. And I'm more interested in, are you clear on how these things flow? Say private insurance, forget the government for a minute. How does how does private insurance paid for? How many ways is it paid for? First, is it paid by the year, by the month? How's it usually paid?
By the month.
All right, it's a monthly premium, okay? Now, again, who pays? What do you think pays? Tell me the variables, huh?
The consumer, whatever the person.
You think the consumer pays?
That's one of the.
That's one way.
Okay.
Huh? The employee might pay it, oh, okay? What?
Or part of it.
An employee and the employer might pay it jointly in some ratio, huh? What else? You're in North Carolina, you see, you would have started with number 3 first.
The employer.
Suppose you were in Michigan or you were in Ohio or somewhere, Pennsylvania, you would have immediately said it's employer paid for by, because what is it related to when it's totally employer related? It's related to usually the collective bargaining, and it's expected that the employer will only pay it all. So that it shows the mores of where you are, that you're even in this order of discussion. If we're teaching at Ann Arbor, then obviously the first thing to be shouted at you, they don't know it any other way, is, I mean, how in the world could you expect an employee to pay for it? I mean, that's ridiculous. It'd be like an employee paying his own wages. They expect to get it, okay? And yet, around here, this shows you what we just talked about, okay? This is the way they expect it. They sit on the board, and then they tell their employees what they'll take out of their pay every month, okay? That's thought of as a norm. See, everything depends on how you think of things, whether they're normal or not, okay? Jointly, it means it's a fringe benefit in part. And now we're in a process of going from this backwards historically because of the take-back, right? We're in an era of take-backs. Chrysler, right, all steel. What do we mean by a take-back?
That's where some of the employee gives up some of the.
They're asked to give up, that the companies are in trouble, and they're really in trouble, and the employees, decide to take back. There's a lot of ways that the employer can ask them to share the costs. So let's start backwards. It's been an industry in which the employer is carrying the whole cost, okay? How might we go about varying this? How many ways could he play with sharing the cost? Miss Young, what could he say to the workers? There's a lot of variables. Try a few of them.
Co-payments.
Okay, he could say, I want you to make a co-payment. Would you give me an example of that?
No.
All right. The employer's been paying it all. Now, how might you co-pay? Say an office visit, what might you do?
Well, the way I understand it is the patient will pay some of the.
Some of that, okay. It could be a fixed dollar sum, okay? $5 or $10 on the office visit, right? It could be moving from total payment to a thing we call, which is another way of major medical, right? Which would say, now you haven't used another word, so what's another word we need? Yeah, you put a deductible into it, okay? How much could a deductible be? What is some big, what do you, how much? 100? How about in North Carolina, what have state employees just been moved to?
200.
To 200. So you see, there's a take back, because they're saying the state government's in trouble, and they've just changed carriers and moved 100 to 200, okay? So if all you spend is 200 in a year, you paid it all, right? That is, and you didn't have a hospitalization. So you've saved them on every score. You've done preventive care. You spent $198, and it hasn't cost them anything. They've got the deductible up to 200. They don't need a copay. They don't worry about a copay. They take care of it all down here, okay? Now, sometimes this is so fixed that after you reach a certain point, it moves into this. See, the two are in tandem. In other words, you co-pay $10 per outpatient office visit until you've had 10 of them equaling $100 of a category, okay? Or you paid enough on prescriptions to equal 100, and then from then on it's under major medical, you see. So major medical then sets in, and how can major medical work, Miss Young? What ways would it work? Would it tell me anything you know about it? First, percentages, what ratios? You could pay over the deductible, 80-20, could be 90-10, right? More likely 75-25, 70-30. Any of you know of variables like this in industry or where your spouses work or anything?
It depends on, like, say psychiatric, a lot of times they only pay 50%.
Okay, yeah. Now there's little ways they have. They can say that all mental services are excluded.
Drug abuse, alcohol.
Okay, that can be reach. That knocks it all out. Or they can say that you have a certain amount, $200 a year, $500. You know, they wait.
Or they will only pay after an inpatient hospitalization.
Okay, or but a variety of ways, right? One way to think about mental health services is to relate it to what historically you find the employers did when they were into prepayment years ago. The only thing they didn't cover was venereal disease. That was a nice thought. Their morality was so strong that if that spread all over the community, it didn't matter to them. They just didn't pay for that, okay? But anything else, the employer in the lumber camp, and we can see this in the old historical documents, totally paid for. The company doctor can get what they. But if you're into this kind of diagnosis, then you pay for it yourself. What else? They can have maternity, right? They can treat it separately, or are there new decisions that might not let them?
Excuse me.
Hello.
Okay, I'm in the right place.
You're in the right place. If your name is Matula.
It sure is.
We're very happy to have you.
I'll just sit quiet until you finish.
That's fine. Let me be sure I have the right time and don't have a stopwatch. About 3? Or, okay. We're discussing payment mechanisms and varieties of things. You may want to sit where you can share with us while we're finishing up, and then I'll introduce you, Ms. Matula. Okay, what we've been reviewing now is that over 2/3 of the dollars are coming now from third parties, right? Less than 1/3. That this breakdown we've taken care of where the government 40% is coming from, where the private 28% is coming from, and how different it is, hospital, physician, and under other, dental, pharmacy, drug, and nursing homes, okay? Total different politics to it, total different reactions to what Medicare does not outrage dentists and pharmacists. They're getting $0 from. What Medicare does under usual and customary, you saw in those early hearings, or anyway, can outrage a medical society. Okay? Outrage hospital. When Medicaid talks about capping, coming across, who would be the most outraged? Any kind of capping? Who? Nursing homes, okay. It doesn't mean other people won't be, but, look at where their income's coming from. Now, flipping back, and perhaps you can share, Ms. Watson, some of that with Ms. Matula. Flipping to the back sheet of the chapter on from Wilson and Newhouser. How much the last full year they're giving the dollars for is 79. What do you think 82 is up to? Roughly. Anyone seen those figures? It's showing how many million at this point? 212 million for all health care expenditures. Billion, excuse me. There are no millions in this business. They don't count.
286?
Yeah, right. It's in excess of $280 billion now, and very few of the percentages we've been discussing have varied. I warned you where they could vary. Private insurance, coming across here on this line, private insurance may be due to collective bargaining and other things before the take-back year. It could have upped the dental, or it was only 23%, you know, it might. Generally, none of these have moved, so far as I know, a great deal, you know, 0.5%, 1% or something. We're dealing with substantially the data we've got here. And I think we were talking, let's talk some more, we got to maternity. We're talking about the ways in which, if an employer was picking up the whole bill, and remember these are parallel now to the ways in which any third party, government bureaucrat, anybody can go at it. What are the ways now to force cost sharing? Talked about co-payments, talked about deductibles. How about categorical? What could they do in this area barring court decisions? What do they already do in standard policies? Right? What kind of thing?
They can disallow.
Well, they could disallow it. They easily disallow it if you're under like 10 months, right? I mean, you're a new employee, but what more than that? They usually have caps on them, you know? And then there's a series of court decisions, and I'm not clear unless some of you all are on. Mr. Yao, you have any data on the way those are? I don't think they're being uniformly, we don't have a pattern yet. You know, when the decisions come down, that it's usually on disability on some aspect, you know. Okay. If these are the main areas, let's say a hospital is getting its dough from, right? Private insurance first, Medicare. That still isn't telling us everything. What's this mean? That hospitals are living on about 30% of charitable donations? Is that what the rest of that means? Huh? What do you think? You think charitable donations? First of all, there are none in the case of doctors, right? Now what about hospitals? You think charitable donations are... What's the reason the establishment sits on the boards of these hospitals? It's because they give their money to them, like you did 100 years ago? What do you think? Huh?
There's a little bit of that, but not much
All right.
anymore.
There once was a lot of this. Remember those dispensaries we talked about earlier? You know of much of it in any hospital that any of you have studied? You know of it being as much as 1% of the budget? It's a strange hospital, probably Columbia Presbyterian or something. You know, there was a reason. In other words, if you want a reason why consumers might ought to, you know, be on boards of hospitals, there is very little reason any longer to have the same people that were there 100 years ago, Rockefellers and similar people, because they once gave the money to build the buildings. You know, there once was a reason, right?
So they do it now just for like community service and political, you know, as far as political reasons?
Well, they're parallel to maybe who sits on the board of trustees of this university. Any reason to have representatives of R.J. Reynolds in the major industry? I mean, it's nice, right? They know how to buy art in Winston-Salem and so forth, but it's connected with how the establishment here runs the state, isn't it? Rather than, and that there's no counterbalancing forces. Are there any like in Michigan? I mean, how much power has the black community got in relation to 22, 24% of the population? You know, leverage. How much power of the working people of the state got? small farmers with large families, not the agribusiness, huh? You think? Well, we have two. We have a senior senator, we have a junior senator. Do you think they represent these farming interests? Small family farmers, Mr. Young?
Yes, the small farmers, they'll say they do.
Huh?
Yes, the small farmers.
They'll say they represent their interests, okay. Well, then perhaps they do, so that explains it a lot anyway, huh? Explains why Representative R.J. Reynolds should sit on the Board of Trustees of the university, right? Okay. What other observations? Remember, let's go back to this. It is going to be very easy to get data on Medicare. And we've been over it, right? We looked at the 70 hearings, the outrageous way in which Congress thought the Social Security administrators allowed the carriers to charge 3 and 4 times what they were paying privately under the, same carriers. But all this data is available to us, isn't it? Annual reports, semi-annual, monthly, all of it's there under freedom of information. Does anybody believe we know very much internally about this except their published schedules? Any question? Okay, you've all read of scandals now. Got fraud and abuse in your mind? We're going to, in a few minutes, have a representative of Medicaid educate us about the problems in this state, and it would be a mistake to see fraud and abuse, although it has to be dealt with, as the central issue of what the administrators have to deal with.
I just have one question that I've always wondered about. Is when you get these insurance, you read what your insurance is offering you, the majority, unless you're covered by an employer with a real comprehensive plan, as far as mental illness goes, or drugs, alcohol, rehabilitation goes, you notice there's always limited coverage in those areas. And I was just wondering, is it because they're just basically what society is all about? They're not really